Wow, 6 years, I can't believe it. It seems like yesterday,
You can
right?
either do this.
So we were very fortunate to
All right, you're good to go.
have Dr. Guzik join us in 2013. She actually did her, went to medical school at Albany Medical School in Albany, New York. Then she did a residency in neurology at the University of Virginia and did her fellowship in vascular neurology at UC San Diego School of Medicine. So she is going to talk a little bit about the management of mild and rapidly improving strokes. You know, that's been a huge issue, is treatment of mild strokes. You know, years ago we didn't really do a whole lot for mild strokes, if you will, but now we're treating them much more aggressively, and I think we've seen a lot of great outcomes. So, Dr. Guzik, thanks very much for joining us this morning.
Thank you.
And you're also, we have such young speakers. So, Dr. Brown and then Dr. Guzik, may I share, is expecting her first child in January.
So he's getting a lot of stroke education even before he's born. So thank you, Rayetta, and thank you for AHEC for always developing such a great conference, and thank you all for being here today. So like Rayetta mentioned, I'm going to talk about mild and rapidly improving stroke symptoms. I think these are always a really tricky part of stroke presentations. We don't know what the best thing to do when people come in with stroke symptoms that, you know, might be improving. Should we treat them? Should we wait and see what happens? And so we'll talk a little bit about that and how our thoughts have evolved over time on it. So I'm going to review a little bit about the TPA indications in history, just so we kind of have a good baseline for that. Talk a little bit about the definitions of mild stroke and rapid improvement, and give a couple examples and the evidence about what we know today to help us figure out treatment for these patients. So most of you here know that really TPA as soon as possible is our mantra. So time is brain, and the acute stroke guidelines have continued to reinforce this over time. TPA was first approved in 1996 for treatment within 3 hours of stroke onset. And then in 2009, we were able to expand that to 4.5 hours. So we're able to continually help treat more and more patients. And as Dr. Brown talked about, in the last hour, now we have treatment options even for patients out to 24 hours. So we're really able to do a lot more for our stroke patients. In 2013, the AHA just reiterated that early treatment is better. So sometimes when we have 4.5 hours, we take 4.5 hours, but we should still really make sure that we're treating as quickly as possible. And so really establish that door to needle time goal of less than 60 minutes. In 2015 is when we started talking about interventional procedures as standard of care for appropriate cases. And then in 2018, like Dr. Brown talked about, we have broadened the window for intervention up to 24 hours. And now we're learning that the goals for door to needle time and door to groin time as well are even being tightened further. So those of you at primary and comprehensive stroke centers know that the door to needle time of 60 minutes is really expected to be standard now. And our goals are now 45 minutes and 30 minutes for groups of patients. So tightening up our stroke evaluation and treatment plans is even more important now than ever. So this is the original paper that gave us the data for TPA, and it was published in 1995 in the New England Journal of Medicine. And so a lot of the inclusion and exclusion criteria that you see for TPA come from this paper. This is pretty unique for TPA as a medication. The majority of medications that we use, we don't necessarily use the inclusion-exclusion criteria from the original study. We've been able to generalize a little bit further. But we really stick to some of those guidelines when we're treating with TPA. So as you all know, those of you in acute stroke care know that the inclusion criteria is really just that they're having an ischemic stroke with a clearly defined time of onset. At that time, it was less than 3 hours, and there's no bleed on CT scan. So we don't need to necessarily prove it's a stroke on imaging. We need to show that it's not a bleed, and we need to clinically diagnose ischemic stroke, and there needs to be a clear time of onset. One of the exclusion criteria was rapidly improving or minor symptoms. And at the time of the study, that was included so that if you as the clinician were at the bedside and said, they're getting so much better, I don't want to enroll them in a study where I don't know if this medication is safe or not, you had a little bit of an out. What we do know is that no patients were enrolled with a stroke scale of 0, but there were a good number of patients that were enrolled with more mild stroke symptoms as well. So in 2008, 2009 is when the window was extended. And again, here's the inclusion-exclusion criteria for that study. And so that's why sometimes we're a little bit stricter about giving TPA in that 3 to 4.5 hour window. The most important one for this discussion is, again, they included, as part of the exclusion criteria, symptoms that are rapidly improving or only minor before the start of the infusion. So they, again, wanted to give you a little bit of an out. If somebody was already improving significantly by the time you were about to give the infusion, you didn't have to enroll them in the study. But let's define mild stroke and rapid improvement. These are might seem like simple concepts when we start thinking about it, but when you're seeing patients, it becomes much more complex. So is it a NIH stroke scale value, or is there an absolute change in the value? So if you improve by 4 points, does that mean it's rapidly improving? It happened really quickly. Should we go based on symptom severity? So should we say, this patient with aphasia is more severe than this patient with dysarthria? I don't always know how to compare those two symptoms in terms of severity. Should we use it based on disability? So potentially a little bit of numbness on one side of your body isn't as disabling as gait ataxia, which is going to lead to stumbles and falls and breaking hips and all that other great stuff that happens in our population. Or is it perceived disability? So maybe I don't think that numbness is that big of a deal, but a concert pianist thinks that numbness in their hand is, their livelihood is at stake there. Should we use a weighted score instead? And I'll talk a little bit about some of those as well, and how the literature has tried to define this a little bit better for us so that we're all using a more consistent definition. So I wanted to step back and just talk about the NIH stroke scale a little bit because, the numbers, it's really pretty enticing to just be able to use a number as a cutoff and say, well, if their stroke scale is less than X, then I'm not going to give them TPA. And for those of you that use the stroke scale on a routine basis, you're very familiar with these cards down at the bottom. But the NIH stroke scale consists of 15 neurologic exam components. It tries to simplify a neurologic exam, which can be a very extensive, very complex exam with, multiple forms of sensation and reflexes and all sorts of stuff, not all of which are really necessary in the rapid acute stroke phase. It ranges from 0 to 42. And as you all know, the reason we use it is because it's accurate, it's repeatable. We can all get certified in the NIH stroke scale and we know what we're doing, and I know that I'm doing the same test that you're doing. And when we talk about it on the phone, you can tell me where you got the points, and I know kind of what that means. It's pretty simple, and it facilitates communication. So when these are the cards that kind of come with the stroke scale, and those are the components of the language exam, which also helps standardize that language exam. Rather than just chit-chatting with the patient and trying to decide if they have aphasia or not, you're really doing a focused assessment of their language. But there's lots of limitations to the stroke scale. So 0 doesn't necessarily means no symptoms or that it's not a stroke. So you'll note that, we typically don't get somebody up and walk them during part of the NIH stroke scale examination. And so if you have some mild ataxia, we're not going to catch that on the stroke scale. It also doesn't mean it's not a stroke. So there's lots of times when patients will improve but still have damage on their MRI the next day. Strokes are also not consistent. So all NIH stroke scales of 2 are not created equal. So you can get 2 points because, grandma comes in with a urinary tract infection, is a little confused, can't answer what month it is or how old she is, or maybe that's her baseline because she has a little bit of dementia. Again, that doesn't mean that it's a stroke, but a 2 for more moderate to severe aphasia is a really big deal. So we can all agree that they're not created equal. And scores are not continuous either. So I can't say that 8 is twice as bad as a 4. There's no real value to that number other than counting the number of abnormal findings that you're seeing when you're doing the exam. It's also very skewed to left MCA strokes. So again, if you have a left MCA stroke, you have aphasia, you're often not able to participate in a lot of the exam, can't answer the questions, can't necessarily understand what I'm saying when I'm asking you to raise your arm, and so you might drift down to the bed. And so I have to give you extra points for that, knowing that it's not necessarily capturing a neurologic deficit, but more just your ability to comprehend. And so we have to use our kind of clinical judgment as we're doing it as well. And a right MCA of equal size might look less bad if we're looking at the numbers specifically. And there's really limited inclusion of the posterior circulation symptoms. So like I mentioned at the beginning, we're not really counting points for vertigo. We're not counting points for ataxia. If you have some weird eye movement abnormalities, you might just get 1 point, but that's a really big deal. And so there's a lot of limitations to this as well. So I think these are all arguments for not using a strict score number cutoff as a exclusion criteria for TPA. And really, just to specify this a little bit more, let's consider some of these mild symptoms. So we've talked a little bit about aphasia. So I think that most of us can agree that even a low score for aphasia doesn't really constitute a mild symptom. I think that communication is so important in everything that we're doing. And if patients are wanting to get back to their previous standard of living, any amount of aphasia is really very disabling. Even a hemianopsia or visual field cutoff can be very disabling. So think about how, while that might not really affect your ability to do an exam in the hospital, if you want to go home and drive to work every day, and I tell you, well, you can't drive to work because you can't see the left side of the world, and so when the cars are coming up alongside you, you're going to get in accidents every day, then that's incredibly disabling. Again, talking about ataxia, I mean, that's one that keeps coming up because we're really just not assessing it. Even severe dysarthria can give us a hint that there's probably a good component of dysphagia or swallowing difficulty as well, and that's going to be disabling. So that could then lead to further complications, can lead to aspiration pneumonia, rehospitalization, and even potentially death. So even dysarthria, a little bit of slurred speech, might be more disabling than we think. And then mild strokes that are really just causing hand weakness. If they're in the dominant hand, again, you don't even need to be a concert pianist for that to be very important to you. So if you're all of a sudden not able to use your dominant hand, that's going to be pretty disabling. So the table below tries to give a little bit more definition to mild stroke. So using the NIH stroke scale, the majority of studies on mild stroke have used a stroke scale around 0 to 5, depending on what those symptoms are, as a baseline for what we're talking about when we're talking about mild stroke. But I think this treat derived stroke criteria, which might be a little bit tough to see, but it really adds a little bit more clarity to that. So they're saying don't just use these strict cutoff of 0 to 5. I mean, 5 is a lot. It could be right face, arm, and leg weakness and some slurred speech, and that seems pretty disabling to me. But they say use that 0 to 5, but along with an absence of any of the following. So the other criteria that we're looking at is complete hemianopsia. So again, knowing that that's going to be very disabling. Severe aphasia. So that only gives you 2 points, but it's very disabling. Visual or sensory extinction, so neglect and really ignoring one side of the world or the other. Any weakness limiting sustained effort against gravity, so giving a little bit more parameter to that weakness finding. And any remaining deficit considered potentially disabling in the view of the patient and the treating practitioner. So that's this catch-all to say it's fine to count something as a mild stroke with a low stroke scale if you don't think that it's going to be disabling, or if the patient doesn't think it's going to be disabling. So what is our goal? Let's step back again. And our goal with TPA is that we're trying to create a better outcome than if we don't give TPA, right? So is our goal no deficit or back to baseline or lack of disability? And to talk about this, we have to talk a little bit about the modified Rankin scale. So this is our stroke disability scale that we use. And you can see that it's a 0 to 6 scale, with 0 being no symptoms at all. So you've completely recovered from your stroke. You don't have any symptoms. 1 is some disability despite symptoms, or no disability despite some symptoms. So you notice a little bit of symptoms, but it's not affecting your day-to-day life. 2 is slight disability, so you can't do everything you used to do, but you can get around on your own. Where we worry about it is 3 and above. That's when you're really needing help, all the way up to 6, which is death. So I think that our goal for TPA is not necessarily to get to a point of no deficit, but it's to get to a point of no disability. So you definitely don't want somebody to get these treatments and then still need a lot of help at home. And getting back to baseline is a really good goal as well for patients who, start out in a nursing facility or start out needing some help. So here's a case example of what could be considered mild stroke based on some of the criteria that we've been talking about. So this was a 75-year-old man. He came in with acute onset aphasia witnessed by his family. You could see his past medical history there, has some stroke risk factors in hypertension and hyperlipidemia. He has a history of colon cancer, but it's in remission, so it's not something we're worrying about currently. His stroke scale was just 2, so he could only obey 1 command and had some mild aphasia. So he got some scans. He got a non-contrast CT, which is the top one, and a CTA. And I'll point out some of the findings here. So you can see the great thing about the brain is that there's 2 sides, so you can always compare one side to the other. And you can see here on the left side of his brain, there's a little bit of hypodensity. So an area where there's already been some cell damage and some death. And then on the CTA, really tough to see, but on a distal branch of the left MCA, there's a cutoff. So there's a clot there that is not allowing blood flow past that point. And that fits with that area where we're already seeing a little bit of stroke. So despite only having a stroke scale of 2, this is a pretty significant area of damage. And when he got admitted and got the MRI scan, you can see that he had this area of stroke on his diffusion sequences, which really fits what we saw in the CT scan. So he had a posterior left MCA infarct, unclear etiology at the time of discharge. The event monitor was still in place so that we could evaluate for atrial fibrillation. He had a mixed aphasia, so he could have some conversation. It was a little circumferential. He would kind of make up some things and get back to the point, but was unable to name or repeat. So this is, again, an example where if you're just chit-chatting with the patient, you might not notice that there's too much aphasia, but if you're really testing specific language components like naming, reading, repeating, you're going to notice more difficulty. And so because of all that, he was discharged home but needed home health and 24-hour supervision and speech therapy. That modified Rankin score, that disability score that we use, was 2. So he can't do everything he used to do, but is able to be somewhat independent. And so while this patient in particular, I used it as an example because he wasn't a TPA candidate when he came in. It was too far outside the window. But I think that we can agree that even though this might qualify in some scales as mild stroke with a pretty low stroke scale, that's not nothing. So he does have some amount of disability and really requires a lot of continual work once he's discharged home. Another example is rapid improvement. So these are patients that are getting better kind of before your eyes, but might not be back to normal. So this was an 83-year-old woman. She was found down with aphasia and right-sided weakness. She has atrial fibrillation, but her family decided that she shouldn't be on anticoagulation because she's had some stumbles and falls. And that's pretty common, that we'll see people coming in potentially without anticoagulation despite high risk of stroke. Has a little bit of dementia, and is monitored for that, but lives at home with her husband at baseline, is able to cook, is able to participate with the family, and does a lot of things at home at baseline. And her initial stroke scale coming in was 18. So she had pretty profound aphasia, was not answering questions, not following commands, and also had right-sided weakness. So pretty clear left MCA syndrome. But we gave her some fluids, went to get some scans, came back, reevaluated her, and her stroke scale had come down to 3. So that's a 15-point drop, and just had some mild aphasia, mild facial droop, and right upper extremity drift. So improving quite a bit. Again, wasn't a TPA candidate because she was found down and there wasn't a clear last known normal time, but it's interesting to think about if you would consider TPA in this patient. So here's her scans, and here's her non-contrast CT scan, and then the CTA. And so unlike the last one, we're not seeing a lot of damage on the non-contrast CT, but I don't know if you can see my pointer, but you can see that on the right side of the brain, so left side of the screen, there's a good MCA coming out right kind of below the frontal skull base with good blood flow on that right side of the brain, again, left side of the screen. But on the left side of the brain, right side of the screen, there's no MCA. So she's missing a blood vessel. There's a big clot there blocking that off. And here's the arrow to kind of point that out for you. And so, like I mentioned, when she came in, we started some fluids on her, and her blood pressure went up from 140 to 180 systolic, and that correlated with her improvement in symptoms. So that blood pressure dependence tells me that there's either good collateral blood flow, there's other blood vessels that are taking over for that blocked blood vessel, or there's just a critical stenosis and it's not completely blocked, but there's a trickle of blood flow getting through there, but that she needs her blood pressure to be over 140 to be able to get good blood flow to the brain and, bring that stroke scale down from 18 to 3. So had her admitted to the ICU and tried to keep that blood pressure up as much as possible, but overnight had a clinical decline and her stroke scale went back to 16. So got worse again. And because she was worse and we knew that there was this blood clot, she was taken to intervention. And you can see the angiogram below. So at the beginning of the angiogram, again, there's no blood flow in that left MCA artery. And then after going in there and working their magic, they were able to open up that blood vessel and get good blood flow on that side. The image on the left is again, the diffusion image from the MRI, and it shows some area of stroke subcortically in those deep structures on the left side. So how did she do? She had a 10-day hospitalization. Unfortunately, her course was complicated by a UTI, as well as some hypertension and trying to figure out what the best blood pressure was for her. She was eventually started on anticoagulation for atrial fibrillation. I think that the stroke scared her and the family into starting the anticoagulation, and then was discharged to inpatient rehab near baseline. So her modified Rankin score, that disability score we were talking about, was 3. So needs some help, but is walking independently, and that's pretty close to what her baseline was, knowing that she had some dementia at baseline and already needed a little bit of help at home. So that's a really great outcome. Again, she's somebody that wasn't a TPA candidate coming in, and that's why she's a good example, because I think both of these cases, if they had come in despite their mild symptoms or rapidly improving symptoms, we would have treated them with TPA. Even though the improvement from 18 to 3, there was still pretty significant deficit. The way that I think about rapid improvement is that there's always potential to go back to that worst case scenario. And when you're in this quick door to needle time, acute evaluation, you don't necessarily have time to wait and see if the 3 is going to stick. So working on getting the TPA ready and stuff like that. And then if she gets back to complete baseline normal, then you can always avoid giving it. But I think both of these cases would have been good TPA cases had they presented in time. But what happens to these patients with mild stroke? So is there a more overall review of these patients in the literature that can help guide us to figure out, is there a cutoff or is there a certain set of patients that shouldn't be getting TPA? Because we know that it's not without risk. So this was an analysis that looked at various definitions of mild. So some of them were just that stroke scale of 0 to 5, and some of them looked at that treat definition. So 0 to 5 plus all of those caveats in terms of symptoms that are going to cause disability are excluded, and so they all just got TPA. And the poor outcome was considered a stroke scale of 2 to 6, so where there wasn't any improvement. About 30% of these patients were treated, and there was poor outcome in about 30% regardless of treatment. Poor outcome, again, being that continued stroke scale abnormalities on discharge. What's really important is down at the bottom, symptomatic intracerebral hemorrhage. It was very safe. TPA was very safe in all of these patients. So there was a very low rate of symptomatic intracerebral hemorrhage. So again, this just helps me where when in doubt, if somebody has mild symptoms, but I think they're disabling, they're going to have a low rate of symptomatic intracerebral hemorrhage, and so I favor treating. And what's the data for TPA? This is another meta-analysis which looked at, I think, about 7 studies, so it really gathered all of that information. And the important part is down at the bottom, you can see that diamond structure, and that shows that when all of these studies are taken together in a large cohort, it favors thrombolysis or favors treatment with TPA. So because of this, though, I think that we all agree that patients, even if they're mild by number, but have disabling symptoms, they should be treated acutely. But what about those that aren't clearly disabling? So either the patient already has a little dementia and says, the numbness isn't going to bother me. I don't really want that risk of bleeding. I know someone that had a hemorrhagic stroke in the past and it was really bad. Or, they have a little bit of dysarthria or something like that. So PRISMS was a multi-center randomized trial, really the gold standard of trials. So we wanted to compare patients with a stroke scale of 0 to 5 that were not clearly disabling. And they defined clearly disabling as inability to return to work or perform basic ADLs. So that makes sense. Only 313 patients were enrolled. It was a really difficult study to enroll. So this was a study that was done at multiple academic centers. Typically, we are pretty pro treating with TPA for disabling symptoms. So it was difficult to find a cohort of patients that had a stroke scale of 0 to 5 that was not clearly disabling, that we weren't clear on if we should treat or not treat. So I think that there's patients that have a stroke scale of 0 and no symptoms, and we clearly shouldn't treat them. There's a cohort that have mild score, a stroke scale score, but pretty disabling symptoms, and I'm going to treat those. There's very few patients that are in that middle where I don't know what to do, that don't have clearly disabling symptoms. So it was difficult to enroll patients and randomize them. But we did get some information from this. And so about 13% of these patients, so about 30 to 35 patients that were enrolled were actually stroke mimics. So these are patients where it ended up that their symptoms weren't from stroke. They were either from complicated migraine, seizure, peripheral problems, whatever else it could have been. And about 3% had symptomatic intracerebral hemorrhage, which is very similar to other TPA trials. But again, there was really poor enrollment. But of those patients enrolled, there was no significant difference in their outcome, which was that modified Rankin score, disability score of 0 to 1. So about 78% of patients getting TPA returned to either baseline or a few symptoms, but not clearly disabling. That's that 0 to 1. Versus 85% of patients of controls, so patients that did not get TPA. So very similar numbers in both sides. So what do we do with this information? I think that we learned from both these meta-analyses where they grouped a lot of the studies together, as well as the PRISM study, that TPA is safe in mild stroke. It's likely beneficial in some patients with mild or rapidly improving symptoms. So I think that there's not a question in patients that have a low number but disabling symptoms. Those patients should get TPA. And it's likely beneficial in some other patients. We just don't know how to clearly define that yet. The next steps are really to improve this definition of mild stroke and rapid improvement and potentially come up with a better scoring system, because I can't say that you have a stroke scale of 1 and therefore you should or should not get TPA. And so that's the most difficult part, is that we, of course, we always want to use our clinical judgment, but when time matters and we're going through the rapid stroke assessment, we want to have a really defined way to treat these patients, especially at some of our centers that don't necessarily have 24-hour neurologists on call. So real life, what to do? Consider TPA. So for mild stroke, really the message is to consider disability rather than the absolute stroke. And I always talk about the risks and benefits with the patient. So if it's one of those things that I'm not sure if it's disabling for them or not, I'll talk to them about it and say, you know, we don't necessarily know what to do with this. Typically for me, it's numbness. If you have a little bit of numbness on one side of your body, it might not be that disabling to you, especially if you're somebody with lots of other medical problems and comorbidities. And I say, if you're okay having this amount of numbness, you have other risk factors that make me concerned about giving TPA. Maybe you've had some GI bleeding in the past. If you're okay with this amount of numbness, I probably wouldn't treat. But if you're very active and still very independent, then that numbness might make a big deal. And so then we talk about TPA. With rapidly improving symptoms, think about how much they have improved, not based on numbers, but based on symptoms. So again, that woman that went from a stroke scale of 18 to 3, she still had some aphasia, and think about why they improved. So for her, it was because we gave her some fluids, and it was blood pressure dependence. And so you want to make sure that if you decide not to give TPA because they've improved so much, that you're then preventing them from, again, going back to getting worse. And consider the worst case scenario so that we make sure that we're treating when we need to. And just a little plug for the other hat that I wear as the telestroke director. When in doubt, call telestroke. So those of you that are at telestroke hospitals, you have help. And we are able to help evaluate that, because so much of this is clinical judgment rather than absolutes. And a lot of times we just need to see the patient and evaluate them and go from there. So I wanted to leave a good amount of time for questions, because this is always a hot issue that everyone has some questions about. So please let me know if any questions have come up and what we can do to help. Thank you. Yes?
For the lady that had the diagnosis of AFib